So I just want to talk real briefly kind of about the overview for this group, kind of some ground rules and what your level of commitment would be. I did put together from the community health assessment some relevant data slides that looked at some of the issues that we're having in terms of youth in our community. I'm going to run through those real quickly. But really the meat of what we're here today to do is to try to start talking about what the actions that we might be able to take to help behavioral health in adolescents in our community. And I'm so impressed with the quality of the people that are here at the meeting. I'm really optimistic that as a group we'll be able to come up with some solutions that will make a difference for our community. So I'm very excited about doing that. And then kind of end on next steps and how we want to proceed after this meeting today. Are there any additions or questions about the agenda before I go on? Give you a silent moment to check on that. Okay, so here's kind of overview of ground rules, and I'm not going to read all of these, but there's one I kind of want to highlight, which is the first one, which is, assume good intention. I know that everyone that's here really wants to, do what they can do to make it better for people in our community. So kind of keep that in mind as we go along. This is a little bit about the commitment. We really want folks to, be here when they're here, and once you're involved, we really prefer that you stay involved if you can. If you have concerns about that, let me know. I'm not anticipating that this will be a really onerous time commitment. I'm hoping that we meet hopefully every 2 to 3 weeks for a while, but after we get some things in place, that commitment may be able to be reduced. We'll just have to see how that goes. But hoping to make this not too onerous on your schedule, but really value-added time for you. And then this is kind of the overall purpose and plan of the team. So there's 3 different age band groups that have been formed. So this is kind of a preemptive group, youth age band group that's going to focus on adolescent behavioral health. We want the teams to meet regularly. Developing links between agencies is critical, and that's something Lori and I have had some experience in over time, and we've found it to be really valuable for people. We really want to maintain the idea of being data-driven, so I'm going to give you some data to focus on today, and then I'll send you out a packet that has even more complete data if you want to look at that. We want to make sure that we have timelines for implementation and measures to look at the outcomes. And we want to make sure that if we get a chance, we review any evidence-based literature that might help us guide us about the actions that we want to undertake. So I'm going to run through some data that has been presented in a number of forums, but I think I've really just selected the slides that relate to youth in our community. And for me, at least, some of this data is pretty sobering. So I'll just run through it, and feel free to stop me if you have any questions as I run through it. So this is kind of a reminder about how we did the community health assessment. We started with online and paper surveys. We had an amazing response. We had 1,200 people respond to the survey. So I think it's for our community, that's a really valid number. We did a series of community forums where we elicited, opinions from people in the community. We talked to 12 key stakeholders in the community that understood health and kind of what the climate in our community was. Kitsap Epidemiology provided us quite an extensive report of quantitative indicators, and I'll send that out to you guys. There are about 160 data points that they looked at. We took those results to a joint board, which is the Board of Health and the hospital board together, gave them that information, went out to the community and presented that information. And we're at the point now where we're starting to develop a revised CHIP plan, and that's part of the work that you guys will be doing with us. And then ultimately we'll present that to the joint boards. This is kind of a review of what I just talked about. We did the community health assessment. We went to the joint boards. We worked with a group that reviewed the community health assessment and asked them kind of to develop some priorities. And before, the priorities had been things like immunizations and mental health and substance use disorder and chronic disease prevention and healthy living. But this group decided that they wanted to do segment the work based on age bands. So that's why we're here in the youth age band. And then there was also a group that some of you participated in that started to look at adolescent behavioral health in our community. And in fact, this little table of information is some of the output from that group that was meeting earlier this year. And they thought it would be helpful to the community to produce kind of a list of services that are available and where they are, and give them some more information about that. So that group did a lot more than that, but that was one of the outcomes that group did. And then that data group that I mentioned that met earlier and reviewed the community health assessment, they took a first early swing at what the priorities for the youth group should be, and did some multi-voting to look at what their highest priorities were, and you can see what the top three were. And obviously, teen suicide and mental health came out at the top, and that's one of the reasons that we're here today. So this is just where we start looking at some of the data from the community health assessment. This is from that survey that we passed out that 1,200 people filled out. And this is what those people felt like the biggest issues facing youth in our community are. Now, this is the entire sample, so it's not youth saying what they think their issues are, it's the community saying what they think the issues are. So I think you have to take it a little bit with a grain of salt, but that was the information that group passed along. And then this is just from the same survey. It's asking the community what they thought would help improve the well-being in Jefferson County. And you can see that there's this is separated out geographically. There's pretty strong agreement among, in our community, a little bit of a difference in South County, but housing, jobs, mental health care, substance abuse, and poverty were the top 5 for the county as a whole. This is not a youth-specific slide, but I just think it has some pertinence to our discussion today. And this shows the changing trend in our community from 1990 to 2018 in terms of the age of our community. And you can see over the 20 plus years of this information that we have gone from being a pretty age diverse community to really being a very old community, elder community. In fact, I think most of you know we're the oldest county in Washington State. We're the 6th oldest county in the United States by average age. So I think this has pertinence for this group because I think youth can be overlooked in this community because there are so many elderly in this community, and I think that's kind of an important framing for us to keep in mind as we go out and do this work. This also is not specific about youth, but I felt like it was important to highlight that the poverty in Jefferson County has been gradually getting worse in comparison to Washington State over time. Both Jefferson County and Washington State have improved, but when you look at how we compare to Washington State, that red box at the bottom is showing that we're statistically significantly worse than Washington State in terms of poverty. And you can see by just looking at the line on the graph that gap has gotten worse in the last few years. This is student homelessness in Jefferson County, and both Washington State and Jefferson County have gotten worse over time. Jefferson County compares a little bit favorably compared to Washington State, but pretty significant problem. And if you look at the subgroups by geography, you see that the tri-area is the most significant area for homeless in our community. This is some information about youth bullying, and this comes from the Healthy Youth Survey. So it's broken down by age groups, 6th grade, 8th grade, 10th grade, and 12th grade. And you can see that, again, for the 8th and 10th graders, we don't compare favorably to Washington State. And in none of those 4 areas do we have we improved statistically significantly. And that if you look at it geographically, it's pretty even across all of the geography. Food insecurity is a little bit difficult to measure, but you can see that there's a significant portion of the population of youth that have food insecurity, 16% in Port Townsend, 13% in Chimacum. And the reason there's an asterisk by Quilcene is the numbers were so small that they were not statistically valid. So that's why there's not information for there. And then information about youth immunizations. And Dr. Parker, I give a shout out to you. We are doing statistically significantly better than we were in the past, but still don't compare favorably with Washington State. But the efforts that you guys have been doing in the past few years have led to a pretty significant improvement in our youth immunizations. So this is where the information starts to get a little bit darker. So this is age of initiation of regular alcohol use. And this is a statistic that's been shown to correlate with alcoholism in adults. And you can see that we are pretty on par with the state. We're not getting significantly worse, but numbers are a little bit worrisome. Youth marijuana use, again from the Healthy Youth Survey, and you can see that in the 8th, 10th, and 12th grade, we compare unfavorably with Washington State, and in the 10th grade group, we are getting statistically significantly worse. And again, geography-wise, spread out pretty evenly, a little bit higher in Chimacum. Youth reporting depressive feelings. So both for Washington State and for Jefferson County, all of these have gotten worse for 8th, 10th, and 12th graders. And for the 8th and 10th graders, we compare poorly with Washington State. So youth who have considerably, seriously considered suicide in the last year, again, both Jefferson County and Washington State have done worse since the last period of measurement. And in the 10th grader, we compare unfavorably with Washington State. And then this is the one that I just find pretty frightening. So these are youth that report actually making a suicide plan in the last year. And because of our small numbers, it's difficult for us to say whether we're doing worse or not, but you can see from the numbers that there's a significant increase. And the really alarming number to me is that 36% of 10th graders have reported developing a suicide plan in the last year. So that's a third of our 10th graders. And then this is looking at youth who have co-occurring depression, suicide, and substance use. And again, we compare unfavorably with Washington State in the 8th and 10th grade groups. And while we're not statistically getting worse, you can see by the numbers that that has increased in the last few years. So that is the end of the data slides. I'm just thought I'd take a minute to open it up for questions that anyone has about that. There's quite a bit more data, and I'll send that out to you after today's meeting. But in the meantime, questions or comments on what you just reviewed? Jenny, I see you have your hand up. Do you have a question?
Yeah, if I'm reading this correctly, it looks like our last data point was 2018. And I would suggest that there's a significant difference between 2018 and 2021 in my experience working with families and youth over the past 2 years in Port Townsend. So I just want to make sure we're paying attention to that.
Yeah, it's difficult to get really current data. Obviously, but you're right, and I think the impacts of COVID, or one of the reasons we're all here today, is that I think this has been made significantly worse by the impacts of COVID in our community. Other questions or comments?
Well, that said, John, I'm wondering if there could be an attempt to do some data gathering among adolescents through the schools to see if there is the kind of significant difference that we're anecdotally feeling.
May I speak, John?
Denise, yeah, go Denise. Yep.
The school districts around the state of Washington had to cancel the Healthy Youth Survey this year because of COVID-19. It was due to be given in the fall of 2020. And so now it's scheduled to be given in the fall of 2021. So to Jenny's point of doing a sort of anecdotal data gathering, I would imagine maybe MCS might have some information, or Cynthia might have some information, but I'm not sure. I'm just guessing.
Dr. Parker, and then back to Jenny.
Yeah, thanks. So I do believe that Jefferson Healthcare is tracking ED visits based on mental health diagnoses and is watching for that specifically around the concern with COVID and the increased isolation. So we may have some data in that area for the more severe emergency room visits. I'm not sure about clinic visits, but we may have that as well. And I just wanted, John, to say too about your comment about the age bands. One of the reasons that I think we decided on the age bands early on was to be sure not to overlook the adolescents. And so thanks for bringing that up. I think that's, like you said, that's why we're all here.
And Jenny, did you have one more comment?
Well, while I recognize that the Healthy Youth Survey is not going to be available till 2021, it feels a little bit like we're operating on data that's not honestly completely pertinent to what we're dealing with now. And I'm wondering if there's some other way, rather than leaning on the Healthy Youth Survey, that we might do our own in-house kind of survey, because kids are in school and we do have access to kids, not as fully as perhaps a Healthy Youth Survey, but we may be able to gather more pertinent and current data separately from the Healthy Youth Survey.
I think that's a discussion that we can have if we feel, like that's a valid avenue to get more information. I would be a little concerned about being able to trend that data, since it's we might not be following the same methodology that's used in the Healthy Youth Survey, but I think that's a topic we can definitely discuss when we get to the actions portion.
Thank you.
All right, any other questions about data? All right. So next step is kind of talking about actions, and I wanted to just do a kind of a validation check with all of you. I showed you the priorities that the group that initially reviewed the data from the community health assessment, and they felt like teen suicide and mental health was the top priority. So I want to validate with this group that you agree that that's the top priority, and that that should be the focus of the rest of our discussion for today. So I guess I'll just say it. Is there anyone that doesn't believe that should be the focus of the work that we're doing? I think it's a no-brainer, but I just want to kind of validate with folks that that's where we are. Okay, great. So here's some considerations. You know, I mentioned that we think, and there actually, Jenny, there's a little bit of data. Lori and I have been gathering some data from the community about use of mental health services and law enforcement and EMS calls that are related to behavioral health. And we have seen an increase in those types of calls during COVID. So it's not exactly youth information, but I think there is some at least strong indicators that we're seeing increases of behavioral health issues related to COVID. And then, the question is, what are the actions or activities that we can take right away that might help reduce the risk of teen suicide or provide support to our adolescent behavioral health community? And then also, there's work that is being done by the ICC youth group. And Kate, maybe you could give just a little report about that work, but we want to make sure that whatever we're doing fits in with these other activities that are taking place in our community, and that we're not duplicating efforts or overlapping with some other services. So Kate, would you be okay just kind of talking about what that group did?
Sure, and many of the participants today were involved with that group. So that group is currently not meeting. The focus was really to put together our recovery and resilience plan and identify projects, some of which were able to be funded through CARES funding, but the kind of implementation for next steps is a little bit unclear, and the local governments have shifted to really focusing on this, it's called the ICG, not to burden us all with more acronyms, the Intergovernmental Collaborative Group that will be looking at ways to further implement the recovery plan that we adopted with the 6 community groups. So it was a fairly short-lived, time-sensitive need that group addressed, and I'm actually thrilled to see this group continue the work that group started. I don't anticipate that group joining forces again, so I think this is a great natural next step, and that CHIP is the right place for this work to live. That said, there should still be overlap with the 4 governmental groups, but frankly, government is, especially in a small city, county, we rely so much on our community partners to implement a lot of our human services programming anyway, which many of you do, of course. So I think this is the right place for it to live.
Great. Kate, are there, 2 or 3 of the main activities that group developed that would be pertinent for this group to hear? Or I actually have some slides that might show some of those things, if that would be helpful to you, or if you want to just.
I could list a few, and actually many of the project proponents are included here. So the Benji project was able to expand further south in the county with their programming with CARES funds. The new Youth Family Navigator through the YMCA was funded through that program. A study lounge at the Proctor House, which is run by Juvenile Services, or partly run by Juvenile Services, was funded. Help me out, other committee members, if you remember specific projects.
The foster care, Angels program was expanded, funded.
Yes, support for foster families through Olympic Angels. Yeah, there are a few, and there was, of course, overlap with the group that you were involved with as well, John.
Yeah.
So, hard to say, things like increasing access to broadband for families, low-income families. That's a cross-cutting project.
Yeah. Well, I think since there's a fair number of kind of overlapping members, that as we have those discussions, if we start to tread on that, we can you know, those team members can speak up and say, hey, there's already an effort going on. So having given that, I think what I would like to do is spend about 15 minutes kind of brainstorming some possible actions and activities that might, that this group feels like might improve the situation for adolescent behavioral health in Jefferson County. So I'm pretty tired of talking and being on the camera here. So this is really an opportunity for you guys to share your thoughts. And if it's okay with you guys, that actually worked pretty well to do the hand raising. If you guys are good to do that, if you just hand raise them, then I'll call on you and we won't have too many people talking over each other. Lori, you are first.
I just wondered if we could minimize the presentation now so we can see people's faces better as they're talking.
Yeah. Thank you, Lori. Great idea. All right, Jenny.
Yeah, something that I've experienced in the community and with 2 years in Chimicum and 2 years now at Port Townsend is what has felt to me like a substantial siloing of services. And that is that there are some wonderful services in the community and each one has some impact in one place or another and sometimes cross impacts, that we do not have a vehicle for actually connecting with some regularity and understanding the resources that are available in a more holistic way. There's a great program out of the University of Maryland, and it's called Teaming, Quality Mental Health Care Teaming, that provides a really nice strategically laid out plan for a community to provide teaming cross mental health support services that I would love to see us really, really embrace and implement. Take some time, but it means that what I do in the schools and what other people do in other places can more completely be connected instead of us, you know, having to reach and grab and pull. So that's one thing I would like to suggest. The other, and I'm happy to email out the document. The other is, if you want, going back to the suicide focus, as many of you know, we had a suicide at Blue Heron in September, a 7th grader, and we had a pretty great response to that. It was wonderful. We teamed up within the district and we, I think, did a good job on that. But one thing that came out of that I'm not sure has found many legs, and that is the intentional and very robust educational opportunity for our adolescents around suicide, something nobody wants to talk about. But there are a number of organizations that provide really very, very good suicide prevention curricula for the schools that would be much more intentional than just I'd like to respond rather than react. And I think we've kind of let that go. COVID has clearly gotten in the way, but down the line, I'd like to see us think more deeply about that.
Great, thanks, Jenny. And you could send out that the information about the more holistic way of connecting services in a community.
It's out of the University of Maryland Medical Center, so I'm happy to send that out.
That'd be great, thanks. Kate, I think you were next. I think you're muted still.
Can you hear me now? Having trouble
Yes.
with the mute button. It's a little fussy. Sorry about that. So I think it would be helpful to me if we could scope the actions that we're talking about here today. Are we thinking near term, long term? And I think there's, you know, some very specific needs short term and then some very different needs long term. And, you know, I don't know if those need to be delineated, but fair to say that we're considering all of them. Is that right?
I think, you know, this group was kind of meeting ahead of some of the other age band groups, and the intent was to really start out by focusing on those short-term actions, and then try to get some legs under some of those, and then look at the more long-term ones. So I would say the focus is kind of on the short-term ones, but if there's a long-term one that we can get started on, I don't think that's terrible, but I think the focus is on immediate actions that we can take, and we're kind of short-circuiting the normal CHIP process of developing a full-fledged strategy, goal strategy, and activities, just so that we can start to get some legs under this.
Okay. In that case, as a short-term potential action, we have seen that anytime we can integrate enrichment activities for kids with the schools, that is most effective, especially for working families. So often enrichment requires paying and driving and a type of parental involvement that's not realistic for a lot of families. And so I would really like to see a more concerted effort toward aligning recreation, athletics, various forms of enrichment with the school system that does not ask more and require more of the schools. We know that they are not able to provide a lot more capacity right now. They're pushed to the limit. But I think unless we find a way to make there kind of a seamless after school opportunity for engagement with youth, that's a critical piece. We lose a lot of kids as soon as they leave school. We lose the ability to engage with them. So the longer term end of that project is actually a dedicated recreation facility in the community, but it sounds like that's outside the scope.
Great. And Dr. Parker?
Thanks. Yeah, I love all those ideas so far. One of the programs that we've been looking at for a little while at Jefferson and just haven't gotten it off the ground is the Zero Suicide program that is internationally recognized and has worked for communities in the U.S. as well, which is it can be a healthcare-based program. And Seattle Children's is working on it right now, but it can also be a community-based program, and there are good toolkits to put together, and that might match really well with what Jenny's talking about. And it does overlap a lot of the different community members. So thinking about what Kate said about involving the schools and trying to keep the kids engaged wherever they are at that time, the Zero Suicide can work really well. So I just put that on the list of things for us to take a look at. And I don't know, Alexa, you used to work at Children, so maybe you are familiar with that.
Yeah, I was peripherally part of the team that was rolling out some of the Zero Suicide initiatives, then also joined a call with the Indian Health Service on Monday as they were doing training for their providers as well. So I just want to add my vote to Dr. Parker's that it has great resources and it's a little bit off the shelf and ready-made, which is nice as well.
Great. Tricia, I'm wondering from kind of the school point of view, what your thoughts are about, kind of integrating with, services that are already operating in the school, and kind of having the sensitivity of what Kate said about really not trying to add more to the workload that's already there at schools.
Well, I don't know if this is off topic or not. I had a little staff crisis. I had to pause for a moment, but we miss terribly our wonderful 4-H WSU after school program. I mean, in our little world, we pack it in there, and they come in droves for those after school programs, and so they're missing that, and they miss that because there's not a lot of other things for them to do after school. They get on the bus and go up to their house in the mountains, and they're by themselves. So we miss that. I'm anxious to have that back in the fall. I think there is a commitment for that. I think it's important to have centers for places like Port Townsend. It's also important to have the approach to the work in Brennan and Pilsen and places like that. So we miss that. I think it's an important part of the lives of our kids. And I think just having that back will be kind of huge for us.
Great. Other thoughts or comments? Denise?
I wonder if we want to reach out to the teen center in Chimacum. I don't know how often they're open right now because of the hybrid nature of the school, but I know the school is trying to open a little bit more robustly now, and I'm not exactly sure. I think that they do their programming every day of the week except for Wednesday, and it's not a really long program because of the transportation issues, and so it's just between the first bus and the second bus, which is about an hour-long program maximum. But I wonder if we want to reach out to them.
Julie, did you have your hand up? Yes.
Yes, it's very touchy. So when I touched it, it went off. So I would like to add about access to mental health. I think being in the schools, we had a huge amount of kids participating in person. And when we shifted to being online, it was really difficult to get kids to attend. And so our numbers adjusted. However, the acuity level of what the kids needed was a lot higher. And so that was really exposed in this process. And so we added we did a proposal to the 0.1% because 3 of the schools of the elementary were not getting getting services from us, and the 0.1% said yes, we think that's a major need in the elementaries. And so now that everybody's going back to the school, we are able to do face-to-face. And we have found in the private practice component, we were about 40% individual for kids, specifically for children. And with COVID, it made it so difficult to provide telehealth to kids doing play therapy and doing those things. And so it was really challenging. And so we've had to adjust, and we went to professionals and providing professional care to therapists. I mean, our therapists were doing professionals and first responders. But the dilemma is these kids got dropped because they didn't want to go because there was that issue. And so our focus, and I think it would be a really great conversation to how do we do it in person? Those after school programs, it's more effective when it's in person. In school, kids learn better when they're in person, and all those little pieces. And so for my team, we are very conscious of being in person, but however, we also want to protect people from not being exposed. And so how do they get access to care? And one of the great things that we have found being in the schools is that kids will come see us in the schools before they'll go see somebody in the community. And so I just think this would be a really great conversation to have. How do we get more kids services in the school? If the 0.1% is 1 day a week, how do we get them more days? And if the schools are losing funding that they can't afford to pay that extra day for schools, how do we get that funding to support these kids in the school? And we're finding it's very effective. So I think that's my piece that I would like to add. And one of the things on the private practice side, there's not a lot of kid therapists out there that are taking private insurance or Medicaid. They're full on Medicaid. And so that's, I think, a really great discussion I'd like to have. So that's my piece.
Great, thanks. Other thoughts or comments?
Julie, I think that counseling is super important, but because we've had our kids in person almost, the whole time, we've had the benefit of having your services, you know, boots on the ground, counselors there, and you're right, they're very, very busy. They're packed full. So thank you.
Dr. Parker, I think you have your hand up. Oh,
Yeah, thanks. So yeah, I totally agree that it's at least for my patients, they're much more likely to see a counselor in school than to come into our clinic. That said, I think we should keep in the back of our mind. The hospital gets different reimbursement than private therapists for therapy, and so we get, because we're a critical access hospital and a rural hospital, we get a higher rate of reimbursement, and we have therapists, but they are only comfortable with adults right now. So keeping that as an access option, if we were able to get more funding to hire somebody within the system, I think that might be a possible solution down the road. So I totally agree. And I was just going to say that I just got an announcement from the Benji Project that they're doing some outdoor projects for girls and non-binary kids on Saturdays in groups, which is great, and outdoors. And so I think, you know, being creative like that is fabulous. So thinking outside the box for all of these programs makes a lot of sense.
Kate, I want to check with you. Your hand is up, but I wasn't sure if it was still up from before or whether you had another question.
No.
You're good. Okay. And Jenny, I think your hand's up. Jenny, if you're talking, you're muted.
Thinking again creatively, I would want to also think about not just counseling for kiddos in school, but counseling for kiddos after school in the school building. Because again, that's for many of our kids, painfully as it is, the school is a safe place for them. And the fact that they're able to receive services within the school setting is a real invitation to a safe place.
So we're coming to the end of our brainstorming time. Are there any kind of last minute thoughts? I've written down some themes that I think that I heard, or things that to maybe get us started on next steps. But before I do that, any other thoughts that folks want to share? Molly?
Oh, thanks. I just wanted to be sure we had the right people in this meeting, and you kind of brought that up with the Teen Youth Center, and I know that Jumping Mouse was on the invite, but probably just couldn't attend. So I just wanted to throw it out there to you guys who know this community to be sure there wasn't anyone else we should have here.
Yeah, Jumping Mouse was invited and was not able to attend. Jenny?
I just think school counselors also have a real depth and breadth of knowledge of the community and what's needed in the community, dealing with kids and families every day. So I would suggest the school counselors be part of it as well.
Denise?
I agree with Jenny and the school counselors, and I would add the student assistance professionals. One that was just hired at Chimacum is Erica White, and then there's a new one that was just hired for Blue Heron Middle School, whose name I don't have yet. And then I also want to second my suggestion of the teen center in Chimacum. And I guess that was it.
And Kate?
Yeah, if indeed there is interest or traction in, I mean, really supporting the schools and developing more integrated programming, I think perhaps maybe more administration from our school districts would be helpful. And then also, I don't know if this is kind of in the works for this group, but I know, and maybe many of you have this already, I know it would be of great benefit to me to better understand kind of what is research telling us are effective interventions, you know, just kind of something of a literature review, you know, what do we know is effective here or in other places, And I don't mean to be creating more work for you, John and Lori, but I wonder if that could be a good use of this group's time, is to be able to share resources like that to help generate some further thinking.
I mean, I certainly think that Lori and I can be a clearinghouse for that type of information. I don't think we're the experts that could, always be the ones to gather that. So I'd say if group members have information, we'd be happy to, take that and distribute it and, just make sure that the group has access to that.
Thank you.
Let's see, Lori has her hand up.
Just quickly, I wanted to say we could take those resources as they're pulled together and put them on the website, on a specific page for this group and the work that we're doing here, so you have it in one place.
Denise?
Oh, I'm sorry, I didn't realize my hand was still up, but in
Okay.
the chat I was typing the substance abuse, mental health services. I don't know whether the last A stands for association or what, but the acronym is SAMHSA, and they have an entire list of evidence-based programs that are for in-school and out-of-school and sports-related that address alcohol, tobacco, and other drug misuse, as well as mental health issues. And anything this group might want to choose from that list, the Community Prevention and Wellness Initiative can support financially. So because that's the list we're forced to use in terms of substance abuse and mental health program strategies. Thanks.
Yep. Jenny, and then I'm going to hit the last few slides so we can kind of talk about next steps.
Thank you, John. Denise, I think you're right on. SAMHSA's got some great stuff. The other thing, I think to your point too, Kate, is that this is not a kid issue. This is a family system issue. And I don't want to lose sight of the fact that while we may be focusing on the kids for something specific, this really is a family system within this community issue. We deal with a lot of families, and I can tell you that the outcomes are what we see in the schools, but it's a totally family issue, so I don't want to lose that.
All right, so I kind of want to go through some next steps. I think what I'm hearing, what I heard, and I'll summarize this if you guys feel like it's accurate, is there were kind of 4 themes that we might start to focus on a little bit more. So one was the point that Jenny made about better integration between and understanding of the services that are available out there, and making sure that one part of the community doesn't have access to a service that another part of the community doesn't have. The second one, and I guess this kind of comes under the issue of, do we have the literature to support it? And it sounds like we do, is the Zero Suicide Program. So Lexa or Dr. Parker, I was wondering if one of you could provide a little bit more information about that program, so that we can get that out to the group and they can kind of look at it before the next meeting.
Sure. Yeah.
Okay.
Probably both of us could.
Okay, great. And then the third theme that I heard was, better support for programs within the schools, after school programs and within school programs, and doing that in a way that doesn't provide more burden to the schools. And then the last theme that I heard was better access to mental health services, both in school, out of school, and after school, in school. This is kind of, we're in the early brainstorming part, but I'll put those themes out if those resonate with you. I think the next meeting that we have, what I'd like to do is validate that we're kind of on the right track with that I captured that accurately. and then start to hone in a little bit on those and see if there's activities that we can take to start to make some traction on those actions, or whether there's other ones that we didn't talk about. I'll also see about including the people that we talked about, school counselors, and more school administration, and maybe someone from the teen center. And in the 2 minutes that we have left, my thought is that it would be good for us to meet every couple of 2 to 3 weeks until we can start to really make some traction on some of these issues. Can you raise your hand if you agree that that seems like a reasonable pace for us to go? And if not, tell me. So I'm seeing mainly hands raised, so I think that seems good. So I'll set something up in 2 to 3 weeks. And in the meantime, think about whether those themes were right, or whether there's work that that I left out of those 4 themes that I heard. And then what I'd like to do at the next meeting is at least pick 1 or 2 of those and do a little bit deeper dive on that. That seemed like a reasonable plan to folks? Yes, no, maybe? Okay, good. All right. Any last minute things for the good of the order? All right, so we'll see you all in 2 or 3 weeks. Thank you so much for your time, and I think this is a really important thing for our community, so I'm very appreciative of your time and energy. All right, we'll talk to you in a couple of weeks.
Thanks,
Thanks, everyone.